So today we are continuing with the gastroenterology. Helicobacter pylori cause peptic ulcer and gastric cancer. More is cytotoxin associated gene. Helicobacter pylori causes peptic ulcer and gastric cancer. More is cytotoxin associated gene. So the question will be asked like this: Helicobacter pylori cause peptic ulcer and gastric cancer. More is vasculative cytotoxin presence in duodenum, cytotoxin associated gene, cell wall protein. H. pylori causes persistent infection in the gastric epithelium, more than half of the world's population, leading to development of severe complications such as peptic ulcer disease, gastric cancer, gastric mucosa associated lymphoid tissue, lymphoma. Several virulence factors including cytotoxin associated gene A, which is translocated into the gastric epithelium via type 4 secretory system, has been indicated to play a vital role in disease development. So here it's clearly written cytotoxin associated gene A. It is called CAG-A. Cytotoxin associated gene A. It is called CAG-A. What is cytotoxin in H. pylori? Pylori is a vacuolating cytotoxin A, is the vacuolating cytotoxin A. Infection with H. pylori strains containing toxic allele S1 form of vacuolating cytotoxin A associated with increased risk of peptic ulceration and gastric cancer. It is called vacuolating cytotoxin A. And also see here, several genes have been implicated in disease related to H. pylori infection, including vacuolating cytotoxin and CAG pathogenicity. CAG is cytotoxin. We read here what is CAG? Cytotoxin associated gene A, CAG-A. Okay, cytotoxin associated gene A. Causes chronic inflammation and significantly increases the risk of developing duodenal and gastric ulcer disease and gastric cancer. Infection with H. pylori is strongest known risk factor for gastric cancer, which is the second leading cause of cancer-related deaths worldwide. Image of intestinal obstruction because newborn pause little meconium. It is an intestinal obstruction because newborn pause a little meconium and persistent vomiting for 24 hours with constipation. What's your action? Laparotomy with resuscitation IV fluid. So there is a picture of newborn who has intestinal obstruction. He passed very little meconium followed by persistent vomiting for 24 hours with constipation. What's your action? Laparotomy with resuscitation fluids. But let's see what were the options given for you for this question. The other options given: urgent laparotomy, measures of NEC. Here to say measures of NEC, they have not mentioned that the infant was premature and other things. So they are suspecting intestinal obstruction because newborn passed little meconium, persistent vomiting for 24 hours with constipation. So laparotomy with resuscitation IV fluids. Laparotomy with resuscitation IV fluids. Laparotomy with resuscitation IV fluids. Regarding appendicitis in children, all of the following are correct except Obturator and hip extension signs are seldom positive in pelvic appendicitis. It is wrong. Obturator and hip extension signs are seldom positive in pelvic appendicitis. It is wrong. Obturator sign is specific. Note, regarding appendicitis in children, manifestation depends on the relationship between cecum and the appendix. Regarding appendicitis in children, manifestation depends on the relationship between cecum and the appendix. Abdominal tenderness is a very reliable sign. Anorexia and fever are common manifestations. Repeated vomiting is an early sign. So, obturator sign is specific for pelvic appendicitis. Obturator sign is specific for pelvic appendicitis. Regarding appendicitis in children, all of the following are correct except obturator and hip extension signs or seldom positive. It is here it is written obturator sign is specific. Regarding appendicitis in children, the manifestation depends on the relationship of the cecum and the appendix. Abdominal tenderness is a very reliable sign. Anorexia and fever are common manifestations. Repeated vomiting is an early sign. Let's see the options given for this question. Manifestation depends on the relationship between cecum and appendix. It is true. Manifestation, they have asked all of the following are correct except, so we have to choose the wrong one. Manifestation depends on the relationship between the cecum and the appendix is correct. Abdominal tenderness is a very reliable sign is a correct. Anorexia and fever are common manifestations. Repeated vomiting is early sign. All are correct. Obturator and hip extension signs are seldom positive in pelvic appendicitis. No, here he has told that obturator sign is specific for pelvic appendicitis. Let's check. Obturator sign indicates presence of an inflamed pelvic appendix. Evidence that the obturator test does not adequately diagnose, evidence shows that the obturator test does not adequately diagnose appendicitis, but can be used in conjunction with other signs and symptoms to make diagnosis. It was introduced by Zachary Cope, an English surgeon. So, obturator sign indicates the presence of inflamed pelvic appendix. Obturator sign indicates the presence of inflamed pelvic appendix. So, how do you do obturator sign? A positive obturator sign is pain that is elicited in a supine patient by internally and externally rotating the flexed right hip. You will flex the right hip. Positive obturator sign is the pain that is elicited in a supine patient by internally and externally rotating the flexed hip. Clinical context, it is performed when acute appendicitis is suspected. In this condition, appendix becomes inflamed and enlarged. The appendix may come in physical contact with the obturator internus muscle, which will be stretched when this maneuver is performed on the right leg. The principles of obturator sign is the diagnosis of appendicitis are similar to that of SURAH sign. Appendix is commonly located in the retrocecal or pelvic region. The obturator sign indicates the presence of inflamed pelvic appendix. Sign of severe dehydration. Sign of severe dehydration is drowsy and hypotension. Drowsy and hypotension. Signs of severe dehydration, sunken eyes, no urine for more than 6 hours, drowsy and hypotension. So you'll choose drowsy and hypotension. tension. Child has difficulty with swallowing solid and fluid on X-ray. Child has difficulty with swallowing solid and fluid on X-ray show air fluid in the distal esophagus. Child has difficulty in swallowing solid and fluid on X-ray show air fluid in the distal esophagus. What is the best investigation? Esophagus manometry. This is achalasia. Achalasia. Let's see the other options. What's given? pH monitoring, barium study, esophagus manometry, endoscopy. So esophagus manometry because you're suspecting achalasia. Esophageal manometry is a test that examines the coordinated muscle movement of the esophagus. The test uses a narrow, flexible, pressure-sensitive tube called catheter. Narrow, flexible, pressure-sensitive tube called catheter. The catheter measures pressure created by the muscles in the esophagus and valves in the top and bottom portions of the esophagus. Esophageal manometry helps determine what is causing these symptoms. Esophageal manometry helps determine what is causing these symptoms, which could be conditions such as achalasia. Esophagus muscle don't help move food down and prevent food from entering the stomach. And also diffuse esophageal spasm. Esophageal muscles contract randomly and interfere with if esophagus looks very dilated or if it appears that the muscles are not coordinated well, you may have achalasia. Your doctor and radiologist often recommend an esophageal high resolution manometry to confirm the diagnosis. Okay. Child 4 months with bilious vomiting. Child 4 months with bilious vomiting, not pass stool, did not pass stool, X-ray double bubble. X-ray double bubbled. Duodenal atresia volvulus as the age is 4 months. X-ray is double bubble, no? Child 4 months with bilious vomiting, not pus stool, X-ray double bubble, duodenal atresia. The double bubble sign is highly suggestive of duodenal atresia. However, other causes of high-grade duodenal obstruction can mimic the signs on kidneys, ureters, and bladder radiograph. Other causes of high-grade duodenal obstruction can mimic signs of kidneys, ureters, and bladder radiograph. It is particularly important to recognize intestinal malrotation and midgut valvulus as mimics of double bubble sign. It is particularly important to recognize intestinal malrotation and midgut valvulus as mimics of double bubble sign. What diseases have double bubble set? Duodenal atresia is the most common congenital gastrointestinal obstruction. However, when double bubble sign is present on prenatal ultrasound, other gastrointestinal anomalies such as jejunal atresia, ileal atresia, intestinal valvulus, and abdominal duplication cysts have been found postnatally. If atresia is proximal to ampulla, the vomiting is non-bilious. The vomiting usually occurs within first 24 to 38 hours of neonatal life, typically following the first oral feeding and progressively worsens if not treated. So duodenal atresia will present to you very early within the first 24 and 38 hours of neonatal life. Significant cause of volvulus is a congenital anomaly. Cause of volvulus is a congenital anomaly known as intestinal malrotation, which predisposes infants to develop midgut volvulus, typically within first few weeks of life. So the significant cause of volvulus is intestinal malrotation, which predisposes the infant to develop midgut volvulus typically within first few weeks of life. Symptoms may include severe abdominal pain, vomiting, abdominal distension, necessitating prompt evaluation and management. It's telling that since the child is 4 months with bilious vomiting, since the child is 4 months with bilious vomiting and X-ray is double bubbled, it can be volvulus as the age is 4 months, because the duodenal atresia usually presents within the first 24 to 38 hours of life. Baby 6 weeks with intermittent vomiting 4 weeks ago. Baby 6 weeks old with intermittent vomiting 4 weeks ago. Pyloric stenosis, once vomiting plus reduced weight, pyloric stenosis. Pyloric stenosis. Okay. Next, a case of tetralogy of, no, a case of uh, a case of tracheoesophageal fistula H type. A case of tracheoesophageal fistula H type. A case of tracheoesophageal fistula H type for diagnosis. It is a H type tracheoesophageal fistula. A case of tracheoesophageal fistula H type for diagnosis also do bronchoscopy. For diagnosis also do bronchoscopy, endoscopy. Case of tracheoesophageal fistula, best investigation NGT and plus X-ray or contrast material. A case of tracheoesophageal fistula H type for diagnosis. So what do you do? Case of tracheoesophageal fistula, best investigations is nasogastric tube plus X-ray. You will clearly see if there is esophageal atresia. You will see coiling of the nasogastric tube. Nasogastric tube plus X-ray or contrast material. Let's see what were the options that were asked here. A case of tracheoesophageal fistula H type for diagnosis, also do bronchoscopy. A case of tracheoesophageal fistula H type for diagnosis, also do bronchoscopy. TEFH type for diagnosis, also do bronchoscopy. A case of TEFH type diagnosis, also do bronchoscopy, but you will do the best investigation is NGT with X-ray and contrast material. Patient came in accident with head trauma. Patient came in accident with head trauma. Patient came in accident with head trauma and admitted to PICU. After several days, he had brownish secretion from NGT. What will be your response? Add ranitidine, then PPI, then fundoplication. Patient came with accident with head trauma, admitted to PICU. After several days, you see reddish brownish secretion from NGT. What will be your response? Add ranitidine, then PPI, then fundoplication, maybe GERD. Add ranitidine. They're suspecting gastritis. Gastritis. All of the following are true about pyloric stenosis except the vomitus bile stain. Incidence, male more than female, 4:1. Onset is generally late in the first month of life. Appetite is good. Jaundice occurs in association. Onset is generally late in the first month of life. Appetite is good. Jaundice occurs. So let's see the options given here. All of the following are true, but incidence is more male than female. True. We know that it is 4:1. Onset is generally late in first month of life. Yes, true. Appetite is good. Yes, they feed but they vomit. Jaundice occurs in association. Okay, I am not sure about it, but maybe correct. Definitely vomitus is bile stained is wrong. We know that pyloric stenosis is non-bile stained vomitus. Baby with running nose, diarrhea with mucus on stool. Best action. Running nose and diarrhea with mucus on stool. Best action is ORS. This looks like viral. Viral infection. Child 2 years on total parenteral nutrition. Child 2 years on total parenteral nutrition on 1000 calories per kg per day. 1000 calories per kg per day. Suppose the child is 10 kg. How much you will give per day? 10,000 calories per day. So 1000 calories per kg per day plus 2 gram protein daily. Plus 2 gram protein daily but no weight gain. Total parenteral nutrition plus 2 gram protein daily but no weight gain. Also has developmental delay, CP. So you have to do gastrostomy with calorie intake 1000 cal per kg. So you have to go for gastrostomy. He is on total parenteral nutrition with 2 grams proteins daily but no weight gain. Also has developmental delay. So you will go with gastrostomy. Gastrostomy with calorie intake 1000 calories per day. So change total parenteral nutrition to gastrostomy. So you what to do? Gastrostomy with calorie intake 1000 cals per kg. Increased risk of intussusception is found in all except increased risk of intussusception is found in all except congenital aganglionic megacolon. Increase in congenital aganglionic megacolon Increase in cystic fibrosis and Crohn's disease. What is this? Let's check the options. Increased risk of interception is found in all except congenital aganglionic megacolon. You don't see the risk of interception in congenital aganglionic megacolon. Chronic recurrent abdominal pain, altered bowel habits, chronic recurrent abdominal pain, altered bowel habits, that means sometimes vomiting, sometimes diarrhea, sometimes constipation, weight loss, anemia in adolescent will suggest inflammatory bowel disease. Okay. Chronic recurrent abdominal pain, altered bowel habits, weight loss, and anemia in an adolescent will suggest inflammatory bowel disease. So increased risk of interception in children. The causes of increased risk of interception in children is some disorders can increase the risk of interception in children, such as cystic fibrosis, that is what was written as CF there in the book, and Henoch-Schönlein purpura, also known as IgA vasculitis, Crohn's disease, and celiac disease. Okay. What are increased risk of interception in children causes, or increased risk of interception in children causes, or cystic fibrosis, Henoch-Schönlein purpura, also known as IgA vasculitis, Crohn's disease, and celiac disease. Increased risk of interception in children causes are cystic fibrosis, Henoch-Schönlein purpura, also known as IgA vasculitis, Crohn's disease, and celiac disease. What is the main cause of interception in children? The cause of interception is not known, although viral infections may be responsible in some cases. It may be caused by abnormalities such as polyp in the intestine or a result of recent intestinal surgery. In most children, there is no abnormality present and the cause is unknown. So there is increased risk of interception in cystic fibrosis, Crohn's disease, but not in congenital megacolon, but not in congenital aganglionic megacolon. Congenital diaphragmatic hernia. Congenital diaphragmatic hernia surgical approach is transabdominal repair. Congenital diaphragmatic hernia surgical approach is transabdominal repair. Most common cause of non-bilious vomiting is GERD. Most common cause of non-bilious vomiting is GERD. If low weight and overfeeding, most common cause of non-bilious vomiting is GERD if the child is low weight. Overfeeding if the child has vomiting, non-bilious, and his normal weight. So how do you differentiate? Most common cause of non-bilious vomiting is GERD if the child has low weight. If the child has low weight, it is GERD, G-E-R-D, GERD. And if overfeeding, if the child has normal weight, if the child has normal weight. What approach is diaphragmatic hernia repair? Surgical repair typically involves primary or patch closure of diaphragm through an open or endoscopic abdominal or thoracic approach or combination. Child presented to ER by accident with bloody stool. Child presented to ER by accident with bloody stool and belt marker appear on the abdomen. GIT, gastrointestinal tract contusion, needs CT. Child presented to ER with accident and there is belt mark on the abdomen. Belt mark appear on the abdomen and there is bloody stool. What is the cause? GIT contusion, needs CT. What is the cause? GIT contusion. Diagnosis of GERD. Diagnosis of GERD is esophageal pH monitoring. How do you diagnose GERD? Esophageal pH monitoring is the best, and esophageal endoscopy for erosive esophagitis. Diagnosis of GERD is esophageal pH monitoring. This is the best, and esophageal endoscopy for erosive esophagitis. Achalasia diagnosis. Achalasia diagnosis is by barium fluoroscopy and esophageal manometry. Achalasia diagnosis is by barium fluoroscopy and esophageal manometry. Case of boy presented by diarrhea. What organism produced toxins on adhesion to intestinal wall? A case of boy presented to diarrhea. What organism produced toxins on adhesion to intestinal wall? E. coli, E. coli, E. coli. A case of boy presented by diarrhea. What organism produced toxins on adhesion to intestinal wall? E. coli. A child do gastroenteritis operation. Child do gastroenteritis operation on total parental nutrition. What occur first? Child do gastroenteritis operation on total parental nutrition. Child do gastroenteritis operation on total parental nutrition. What occur first? Increase amino transferase, LFTs. Child do gastroenteritis operation on total parental nutrition. He is on total parental nutrition. What occur first? Increase amino transferase, that is increase in LFTs, increase in LFTs. So let's see the option here. Child do gastroenteritis operation on total parenteral nutrition. What occurs first is the increase in the amino transferase, LFTs. So the other options given here is indirect bilirubin, bile acid alkaline phosphatase, but you will choose increase amino transferase. Next, scenario about intussusception. Scenario about intussusception. X-ray abdomen done. What next step? Scenario about intussusception. X-ray. Usually we are doing diagnosis by ultrasound abdomen. Usually we are doing diagnosis by ultrasound abdomen done and interception. So double contrast air enema. Double contrast air enema. Double contrast air enema. But it depends on they usually for the diagnosis abdominal ultrasound is needed. For the diagnosis abdominal ultrasound is needed. You don't diagnose interception when X-ray. But if they have given that the diagnosis is confirmed, you will choose double contrast air enema. Otherwise, you'll go for abdominal ultrasound. Mother of 2 years child presented to you complaining of progressive jaundice. Mother of 2 years child presented to you complaining of progressive jaundice of her child. History of jaundice in his uncle. Progressive jaundice of her child. History of jaundice in his uncle. Progressive intrahepatic cholestasis. Mother of 2 years old complains of progressive increase in jaundice of her child, and her uncle also had jaundice. So it is running in families. Progressive intrahepatic cholestasis. Progressive intrahepatic cholestasis. Progressive intrahepatic cholestasis. Progressive intrahepatic cholestasis. Disease needs probiotic. The disease that needs probiotics is cystic fibrosis. The disease that needs probiotic is cystic fibrosis. No, here. We were here. A child presented with mild gastroenteritis, you will manage him with a child presented with 50 ml per kg of ORS over the first 4 hours, then 100 ml with each bowel motion. A child presented with mild gastroenteritis, you will manage him with ORS. A child presented with mild gastroenteritis, 50 ml per kg, 50 ml per kg of ORS over the first 4 hours, 50 ml per kg of the ORS over the first 4 hours, then 100 ml after each loose stool. 50 ml per kg of ORS over the first 4 hours, then 100 ml with each loose motion. Administration of oral rehydration. So if mild dehydration, what is done? If mild dehydration, what is done? 50 ml per kg of ORS is given over the first 4 hours. 50 ml per kg is given over the 4 hours for mild dehydration, and 100 ml per kg of ORS is given for 4 hours for moderate dehydration. 50 ml per kg is given for 4 hours for mild dehydration and 100 ml per kg for moderate dehydration. Then for each diarrheal stool, for each diarrheal stool, an addition of 10 ml per kg, an addition of 10 ml per kg, that is up to 240 ml, up to 240 ml is given. 10 ml per kg up to 240 ml is given. After 4 hours, the patient is reassessed. If signs of dehydration still persist, the same volume is repeated. So generally 50 ml per kg for 4 hours is given for mild dehydration, and 100 ml per kg for 4 hours is given for moderate dehydration if the child is tolerating orally well. And also after each loose stool you have to give 10 ml per kg up to 240 ml. In older children and so child presented with mild, so since here it's given mild gastroenteritis, 15 ml per kg, 50 ml per kg of ORS over the first 4 hours, then 100 ml per kg with each loose bowel motion. But here 100 ml, we don't know, 10 ml per kg with each bowel motion. So why over the first? Okay. 50 ml per kg of ORS over the first 4 hours. Okay, to prevent gluten diet, do intestinal biopsy, celiac, atrophic villi. To prevent gluten diet, do intestinal biopsy, confirm the diagnosis, celiac, you'll have atrophic villi. Best to diagnose protein malabsorption. Best to diagnose protein malabsorption, alpha 1 antitrypsin. Alpha 1 antitrypsin. Ileocecal intussusception is common. What about ileocecal intussusception? Ileocecal intussusception is common. What about ileocecal intussusception is due to previous abdominal surgery. Ileocecal intussusception is common due to previous abdominal surgery. Neuronal defect at the mesenteric plexus development leads to Hirschsprungs. Neuronal defect at the mesenteric plexus development leads to Hirschsprung's disease. 11 years old, known case of cystic fibrosis, development of recurrent abdominal pain, which is improved when lying supine. What is the best investigation to diagnose the condition? Serum amylase, pancreatitis, severity by albumin. 11 years old, known case of cystic fibrosis, developed recurrent abdominal pain, which is improved when lying supine. 11 years old, known case of cystic fibrosis, developed recurrent abdominal pain, which is improved when lying supine. What is the best investigation to diagnose the condition? Serum amylase, that is pancreatitis, but severity is by albumin. Child notice yellow eye by exam, normal lab. Child notice yellow eye by exam, normal lab, bilirubin normal. What next to do? Abdominal ultrasound. You notice jaundice in a child by examination, but your lab is normal and bilirubin is normal. You notice jaundice in a child by examination, but lab is normal, bilirubin is normal, then you will do abdominal ultrasound. Mother of 2 years child presented to you complaining of progressive jaundice of her child history. Progressive intrahepatic cholestasis. Disease needs probiotic cystic fibrosis. Pyloric stenosis causes metabolic alkalosis. Hypokalemic, also hypokalemic metabolic alkalosis. Most common cause of intestinal obstruction in children, intussusception. Most common cause of intestinal obstruction in children, intussusception. Most common cause of intestinal obstruction in children, intussusception. Child suffering from constipation on lactulose drug, 1 mg per kg, not improved. Increase the dose. Child suffering from constipation on lactulose, 1 mg per kg, not improved. Increase the dose. 0.7 to 2 mg per kg per day. That is 1 to 3 ml per kg per day. Can be given BID or QD or BID 24 to 48 hours for response. Child suffering from constipation on lactulose, 1 mg per kg. Increase the dose. It can be given up to from 0.7 to 2 mg per kg per day. So increase the dose. It can be given BID or QID and may require 24 to 48 hours for response. Baby with vomiting, abdominal pain, abdominal distension. Baby with vomiting, abdominal pain, abdominal distension. Image of baby, there is an image of baby with severe abdominal distension. X-ray shows multiple air fluid level. What to do? Refer, urgent referral to surgery. Baby vomiting, abdominal pain, abdominal distension. This might be intestinal obstruction. Severe tension, X-ray, multiple air fluid level. What to do? Refer to surgery. Okay, 5-year-old child is noted to be pale and iron deficient. A 5-year-old child is noted to be pale and iron deficient. Upon questioning, his family reports several episodes of grossly bloody maroon stools. Which of the following is likely explanation for his anemia? Meckel's diverticulum. Maroon stool is characteristic of Meckel's diverticulum. 5-year-old child is noted to be pale and iron deficient. Upon questioning, his family reports several episodes of grossly bloody maroon stools. Grossly bloody maroon stools, which is the following is the likely explanation. Meckel's diverticulum. 7-year-old child presents with pallor during routine monthly review. A 7-year-old child presents with pallor during routine monthly review. He has Crohn's disease, which was resistant to treatment. He recently had a resection of terminal ileum and ascending colon for extensive strictures. On examination, weight and height are below third centile. Pallor, weight and height are below third centile. Pallor, CBC, HB, 8 gram per deciliter. MCV 106 femtoliter, MCH 30 picograms. Peripheral smear shows hypersegmented neutrophils with numerous macrocytic RBCs. RBCs folate level 160 micrograms per ml. What is the most likely cause of this anemia? Vitamin B12 deficiency. Megaloblastic anemia due to vitamin B12 deficiency due to resection of the ileum, which is the site of its absorption. Okay. 7-year-old child presented with pallor during routine monthly review. He has Crohn's disease, which was resistant to treatment. He recently had resection of the terminal ileum and ascending colon for extensive strictures. On examination, weight and height are below third centile. Pallor, CBC HB 8 grams, MCV 106 femtoliters, MCH 30 picograms. Peripheral blood smear shows hypersegmented neutrophils with numerous macrocytic RBCs. RBC's folate level is 160 micrograms per ml. What is the most likely diagnosis? Vitamin B12 deficiency, because it gets absorbed in the ileum. Megaloblastic anemia due to vitamin B12 deficiency due to resection of the ileum, which is the site of its absorption. 8 years old have malaise. 8 years old have malaise with abdominal pain. 8 years old have malaise with abdominal pain. On examination, hepatomegaly, malaise with abdominal pain. On examination, hepatomegaly, she shows cyst in the liver. Echinococosis. Okay, 8 years old with malaise and abdominal pain. On examination, there is hepatomegaly. CT showed cyst in the liver. Echinococcosis. Echinococcosis. Child has pancreatitis after fall from bicycle. Lipase 310. What to do? Child has pancreatitis after fall from bicycle. Lipase is 310. What to do? What is this? Reset bowel and IV fluids. A piece of meat impacted in esophagus. What is the best method to remove it? Endoscopy. Endoscopy. 10 years with epigastric pain. He took antacid with no effect. The investigation for diagnosis is study for H. pylori. 10 years old epigastric pain. He took antacid, no response. A study for H. pylori. Diabetic female, long lasting, presented by liver cell failure. Liver biopsy show for fatty liver. Diabetic female, long lasting, presented by liver cell failure. Liver biopsy shows fatty liver. Outer glistening layer of colon has no blood supply. Cirrhosis. Outer glistening layer of colon has no blood supply. Cirrhosis. Case of Gilbert syndrome. What's the best diagnosis? Total bilirubin. Case of Gilbert syndrome. What's the best diagnosis? Total bilirubin. Outer glistening layer of colon has no blood supply. Cirrhosis. Child on neocate formula feeding. What indication for that? Short bowel syndrome. Child on neocate formula feeding. Neocate formula is for allergy, right? Why short bowel syndrome? Neocate formula is for allergy. The serosa, the visceral peritoneum, serosa or visceral peritoneum is a membrane that lines the outer wall of the transverse colon. It is continuous with the transverse mesocolon and the mesentery that suspends the transverse colon. Neocate has been shown to promote healthy growth in infants and children with food allergies or gastrointestinal conditions. All Neocate products are for children with food allergies and related GI conditions designed to help manage these conditions. Uh, Child with severe bleeding from the rectum, age 12 years, with mild abdominal pain without any abnormality. What is it? A child with severe bleeding from rectum, age 12 years, with mild abdominal pain without any abnormality. What is the first step in managing? Radionucleotide study, severe bleeding from rectum. What about urgent blood transfusion? 12 years old with rectal bleeding, colonoscopy done, showing what is the diagnosis. 12 years old with rectal bleeding, colonoscopy done, showing what is the diagnosis. Juvenile polyposis. 12 years old with rectal bleeding, colonoscopy done, showing Juvenile polyposis, the gastric hormone which increases gastric secretion and potentiate the effect of vagal stimulation. The gastric hormone which increases the gastric secretion and potentiate the effect of vagal stimulation is gastrin. Gastrin is a peptide hormone that stimulates. Gastrin is a peptide hormone that stimulates secretion of gastric acid by parietal cells. Gastrin is a peptide hormone that stimulates secretion of gastric acid by parietal cells. Child undergo jejunal resection with intact ileocecal wall. Child undergo jejunal resection with intact ileocecal wall. No vitamin B12 deficiency. He is under risk of bacterial overgrowth. Child undergo jejunal resection with intact ileocecal. No, he is under risk of bacterial overgrowth. Case of gastrochisis, 10% atresia. With image, most common is small defect, normal cord position, cardiac defect, and matted intestine. Most case of gastrochisis, 10% atresia. The most common is small defect, normal cord position, cardiac defect, and matted intestine. Elevated alpha-fetoprotein is commonly in hepatoblastoma plus yolk sac. Elevated alpha-fetoprotein is commonly seen in hepatoblastoma. Elevated alpha-fetoprotein is commonly seen in hepatoblastoma. Most common abdominal tumor in toddlers is nephroblastoma Wilms. Most common abdominal tumor in toddlers is nephroblastoma Wilms tumor. Most common abdominal tumor in toddlers is nephroblastoma Wilms tumor. Type of diarrhea in celiac disease, osmotic. Type of diarrhea in celiac disease, osmotic. Type of diarrhea in celiac disease, osmotic. Child with vomiting and diarrhea, picture, suggest it was multiple air fluid level. Child with vomiting diarrhea, suggest it was multiple air fluid level. What is the finding that make you do surgical referral? Child with vomiting and diarrhea, picture. Child with vomiting and diarrhea, picture, suggest it was multiple air fluid level. What is the finding that make you to do surgical referral? X-ray finding. What is the finding that make you to do surgical referral? X-ray finding. Diagram of hepatitis A infection. Answer will be hepatitis A virus. IgM appear in the blood before clinical jaundice. IgM appears in the blood before clinical jaundice window phase. Diagram of hepatitis A infection. The answer will be hepatitis A virus. IgM appears in the blood before clinical jaundice. Hepatitis A infection. IgM appears in the blood before clinical jaundice window phase. Neonate 2 weeks old. On day 10, neonate 2 weeks old on day 10 develop vomiting clear. Today became greenish with abdominal distension. On day 10, develop vomiting clear. Today became greenish with abdominal distension and tenderness and bloody stained mucus stools. What will you prevent oral feeding? There is abdominal distension, tenderness, bloody stained mucus stool, blood stained mucus stool, and prevent oral feeding. That is NPO. It is going with necrotizing entero. Preterm 32 weeks on preterm formula develops abdominal distension, greenish yellow discharge from NGT. Best action, stop feeding. Necrotizing enterocolitis, stop feeding. Retrocecal appendix, what sign is needed to diagnose? So was retrocecal, obturator, pelvic. How do you remember retrocecal appendix? So was sign. Obturator for pelvic, P not with P. Obturator for pelvic, so was for retrocecal. So you can remember retrocecal, PR, per rectum, retrocecal for psoas sign for retrocecal, OP, obturator sign for pelvic, P not with. Okay, patient with ulcerative colitis, treatment sulfasalazine and another drug may be azathioprine, more liable for damage of folate. Patient with ulcerative colitis, treatment sulfasalazine and azathioprine. Patient with ulcerative colitis, treatment sulfasalazine and azathioprine. You can also add folate. You can also add folate. Folate. TOF, tetralogy. No. Tracheoesophageal fistula, picture of coiled nasogastric tube with history by dribbling, esophageal atresia. Tracheoesophageal atresia, picture of coiled nasogastric tube and history of dribbling, esophageal atresia. Swelling in the lateral side of the neck, firm consistency. Swelling in the lateral side of the neck, firm consistency, branchial cyst. Thyroglossal cyst is a midline swelling. Thyroclastal cyst is a midline swelling. Thyroclastal cyst. Swelling in the lateral part of the neck is branchial cyst. Branchial cyst form inconsistency. Pancreatitis is caused by all except measles. Measles doesn't cause pancreatitis. Pancreatitis is caused by all except measles. Measles does not cause pancreatitis. Amount of dextrose in ORS amount of dextrose in WHO ORS packet 13.5 grams. Amount of dextrose in WHO ORS packet 13.5 grams. Amount of dextrose in WHO ORS packet 13.5 grams. Esophageal atresia by X-ray, we can see upper part, esophageal pouch. Esophageal atresia by X-ray, we can see upper part. Esophageal pouch, and we can see air in the abdomen. By X-ray, we can see upper part esophageal pouch, and we can see air in the abdomen. We can say there is lower tracheoesophageal fistula. A patient with facial swelling, abdominal pain, ascites came to ER and received albumin. Patient with facial swelling, abdominal pain, ascites came to ER and received albumin. Becomes deteriorated. Becomes deteriorated, ill, disturbed conscious level. What's the mechanism? Shift of intracellular fluid to extracellular space. Shift of intracellular fluid. So, patient with facial swelling, abdominal pain, ascites came to ER, received albumin. Becomes deteriorated, ill, disturbed consciousness level. Shift of intracellular fluid to extracellular space. Elevated hemoglobin A2. is associated with renal failure, in which case Wilson's disease. Elevated hemoglobin A2 is associated with renal failure, in which case Wilson's disease. Elevated hemoglobin. So this is vitamin A deficiency, bite out spots. Vitamin A deficiency, bite out spots. 2 months old infant on absolute breastfeeding develops diarrhea. Causes are true except decreased galactase. 2 months old infant on absolute breastfeeding develops diarrhea. Terms hold absolute breastfeeding develops diarrhea. Case of hepatomegaly and jaundice, labs showed reduced ALT, reduced What is the cause of hyponatremia? Reduce oncotic pressure. What is the cause of hyponatremia? Reduce oncotic pressure. Leukemia patient with bone marrow transplant 3 weeks back presented with jaundice. Leukemic patient with bone marrow transplant 3 weeks back presented with jaundice.